So the Myeloma XI trial is, of course, a fantastic resource that was really only possible through contribution of many, many physicians around the country, and of course, particularly many patients and their carers around the country. And not only in that they took part in this trial, which will hopefully have an impact on what drugs can be used in the UK, but also because they gave material, bone marrow material. We all know bone marrow biopsies are painful procedures, and these patients really underwent these bone marrow biopsies in part to contribute to research, which is fantastic. It's brilliant. Having that resource, and I'm really privileged and feeling privileged that I can work on these, does open the opportunity to identify biomarkers of response, of early relapse. But we do know that myeloma is a disease that is somewhat difficult in terms of its genetic makeup. There are many, many changes in the genome of myeloma patients. And although we have already come pretty far at the moment, there are still a number of clinical behaviors that we can't really well predict. So one of the initiatives that we're doing at the moment is really go into much more depth than before in terms of our genetic analyses. A method called whole genome sequencing, which really looks at every single base in our genome, has luckily become accessible and, at least in research terms, become affordable to perform on larger patient numbers. That was impossible some 5 or 10 years ago, when it would just have not been practically feasible. The advantage here is that we're unlikely to miss anything that is really in the genomic sequence, because we're just sequencing everything. But there is more investigations needed. We need to investigate other factors such as gene expression, for example, which can be powerful in myeloma to predict outcome, and put all of these puzzle pieces together with also features of how the patient presents, whether they're frail, whether they're fit when they're first diagnosed. So we've seen similar initiatives happening in, for example, acute leukemias, which are always a slight step ahead because they can get the material more easily. And it's very promising. So we will go down that route, and we hope that it will benefit both, hopefully, the young and fit population in terms of that we can really intensify treatment approaches, but hopefully it will actually also benefit the vast majority of patients, which are actually more on the side of on the other side of 65 or older even, and might be frail, because what the prospect there could be to actually spare toxicity, to really use the drug that works, maybe at a lower dose even, and at intervals that are actually better tolerated for a patient that has probably already 1 or 2 comorbidities. So I think this, as we call it, stratified medicine or precision medicine, holds a lot of promise for different patient groups. We also have, thanks to really the involvement of Myeloma UK, which is a fantastic patient charity that also does a lot of investment into research, the opportunity of running a Highrisk trial, as we call it, for the younger and fitter population with myeloma, where we do enable this population to have access to really novel therapies and combinations thereof that unfortunately couldn't be accessed at the moment on the NHS. This trial will hopefully open within the next 1 or 2 months and be rolled out really across the country in the Myeloma UK treatment centres, but it will reach out to the linked hospitals as well, so hopefully we will get really a good coverage for that. It will be internationally also one of the first trials that really does very thorough central genetic testing, and we will hopefully generate a lot of insight from that will ultimately translate into patients with high-risk disease being able to access drugs that they would otherwise just not be able to access. For the elderly patient population, there's a trial now upcoming that is led by Professor Graham Jackson and Professor Gordon Cook that will take a slightly different angle. And with the knowledge that we have at the moment, it looks at whether patients might benefit from actually dose reductions of treatments that are already used, so that patients can stay on treatment longer when they're frail. We do know from other trials that patients that are elderly and frail often struggle with even the first cycle of treatment, the second cycle of treatment, and some of them might even discontinue therapy and that way not benefit from treatment. So these approaches are actually now looking at this population specifically and whether modification of treatment can help them already.